Now, another condition of the inner ear which leads to only vertigo is a inflammation of the vestibular nerve. It is inflammation only of the vestibular nerve. So there is only vertigo here. This is what is known as vestibular neuritis. So it is the acute inflammation of the vestibular nerve. Yes, this can follow usually viral infections of the vestibular nerve. And when there is an inflammation of the vestibular nerve, we can understand that this will not be episodic on posture change, right? It will happen continuous. It will be a continuous severe vertigo lasting for at least 3 to 7 days. So at least 3 to 7 days will be a severe vertigo, severe and continuous vertigo. Is that very clear? So nowhere can you confuse it with BPPV. What your problem is that whenever such a question is given of vertigo, you confuse it with Meniere's or you confuse it with labyrinthitis, right? Because there also it is a continuous vertigo. So how can you differentiate that this vertigo is not Meniere's, it is not labyrinthitis? Can you tell me? Yes? Yes, there the whole of the inner ear is involved. That is why I have divided it into different modules. Here it is only the vestibular nerve. So yes, so whenever there is a patient who has come with continuous onset, continuous with very severe acute onset, continuous vertigo, then you always have to rule out whether it is an inner ear pathology involving the whole of the labyrinth or not. How do you do that? By asking the history of hearing loss, history of fullness in the ear. Yes, so all this will not be present here. Here there will be only one thing, and that is vertigo. So already the Meniere's, labyrinthitis, all that is ruled out. Now another thing, when the patient comes with acute onset vertigo. Yes, as we have already seen when we did the vestibular physiology and the test of the vestibular function, that it can be only vertigo, can also be the presentation of stroke of the cerebellum. Yes, some early cases of stroke of the cerebellum present only with vertigo. So that is why when you are not getting any history of inner ear pathology, always take the other history of other cranial nerve involvement. Because if it is a cerebellar stroke, there in that area of the brainstem, we have other cranial nerve nuclei also which will be involved. So always take the history of diplopia. Whether it's diplopia, there is dysarthria, there is ataxia, there is dysphonia. So all the sixth nerve, the 9th, 10th, 11th, all these cranial nerves also just test for that. There is any motor weakness, there is sensory involvement, paresthesias, yes. So any central involvement, look for any central involvement. So if any central involvement is there, then it very easily tells you that this is a central origin vertigo that the patient is having. Maybe this is a patient of stroke of the cerebellum. But sometimes in early stroke, there are no other features other than vertigo. So that is why this vestibular neuritis is very, very important. But have you understood how you approach? Whenever the patient has come with vertigo, the first thing is, how is the vertigo? Is it episodic? Is it on posture change? Is it on loud sounds? Is it on pressure changes? Yes. So all this will totally give a different direction. If it is on posture change, it is BPPV. That is the most common. Yes. Most common cause of vertigo. Very easy to treat also. If it is only vertigo is present only on pressure changes or on loud sound, then you have to rule out any fistula or abnormal opening, that is third window. Right? So when it is acute onset severe vertigo which is continuing, it is continuous, then you have to think of whether it is a Meniere's, whether it is labyrinthitis, whether it is vestibular neuritis, or whether it is cerebellar stroke. Is that very clear? So now the inner ear pathologies like Meniere's, labyrinthitis can be very easily ruled out by finding out whether there is hearing loss also or not. The central pathology can be ruled out very easily by seeing any central involvement, whether it is there other cranial nerve involvement or weakness, motor or sensory weakness is there or not. Now, when there is only vertigo, no other symptom, then only two things have to be ruled out, and both these two things are very, very important. One is vestibular neuritis, second is early cerebellar stroke, where the stroke has not yet progressed to involve the other areas. So no other involvement is seen, and this is a very crucial phase where you are in. If the patient has come to you, all the onus is on you, because if it is a cerebral stroke and you diagnose it now itself, when the patient has just one symptom, and that is of vertigo, then this is the golden period where the stroke can be stopped and the changes can be reverted back. So how do we differentiate a vestibular neuritis from stroke is our next aim to find out when no history of peripheral or central pathology is present. So how do we do that? Yes, so that can be done with the help of a test which is known as Hint's test. Hint's test. What is Hint's test? Hint's test is head impulse. HI is head impulse. Head impulse. N is nystagmus. Nystagmus, and TS is test of skew. Test of skew. Okay, so first we will see nystagmus, which we already know. So we know that if any patient has vertigo, we can look for spontaneous nystagmus, or we can make the patient look here and there, and we can look for gaze-evoked nystagmus. So the nystagmus characteristic for vestibular neuritis, it is a peripheral origin nystagmus, so it will have all the characteristic of peripheral nystagmus. So what will be the characteristic of nystagmus of vestibular neuritis? It will be of peripheral origin, peripheral type. This will be of central type. Cerebellar will be of central type. Yes, so direction of nystagmus. Yes, if it is a peripheral nystagmus, the direction of nystagmus is always fixed. It is always towards the which side? Yes, it is always towards the more active side. Vestibular neuritis is a disorder which destroys the labyrinth. The labyrinth becomes hypofunctional. So in that case, if the left labyrinth has become hypofunctional, the direction is fast component or slow component. Fast component will be towards the active side. That is the normal side. So here it will be fixed and it will be towards normal. Towards the active side. Active, that is a normal ear. Normal. Yes. Whereas central nystagmus is a direction changing. The moment you see a direction change in nystagmus, when the patient looks towards the right, it is towards the right. When the patient looks towards the left, it is towards the left. So direction changing nystagmus. That tells you it is a central origin nystagmus. A peripheral origin nystagmus disappears by optic fixation. Optic fixation, it disappears. The moment you ask the patient to fix his eyes to your finger or to your nose or to the camera, anywhere, it will disappear. So it will disappear. Peripheral origin will disappear, whereas central origin will not disappear. Will not disappear. So now let us quickly have a look at how the nystagmus of a peripheral origin of vestibular neuritis and how of central origin appear like. Before you see the video for how a nystagmus of the peripheral and how a nystagmus of the central origin, how the nystagmus of BPPV or how nystagmus of vestibular neuritis, how they appear. Yes, my dear students, I know that most of you would be seeing the nystagmus for the first time. So yes, just try to notice the gross things in the nystagmus, whether you are able to make out or not that there is a nystagmus. If possible, yes, what the direction of nystagmus is, so that when you go to the clinic, if you see any patient, at least if you are able to make out that there is a nystagmus, would be a wonderful thing. When you see it repeatedly again and again and again, it is only then that you actually can see and tell immediately, yes, that this is the direction of nystagmus. Yes, this is a nystagmus which is vertical, which is horizontal, or there is a torsion associated with that. So when you see this video also repeatedly, you will see that you are able to appreciate the things better. Yes, if you are expecting that you will see it once and you will know everything, that will be maybe expecting a little too much from yourself. So just see this video and try to appreciate the gross things. Later on, when you see it repeatedly again and again, yes, you will be exactly, the moment you see the nystagmus, you will be able to say that this is this direction nystagmus, this is a horizontal or vertical nystagmus, it is associated with torsion or not. So yes, let us now have a look. This is a patient who has come with a complaint of continuous vertigo for around 5 hours now, and there is no history of any peripheral involvement, no history of hearing loss, of tinnitus, of ear fullness, which can be suggestive of an inner ear or peripheral involvement. There is no history of any central involvement, like no history of cranial nerve involvement, no diplopia, no dysarthria, no dysphonia. There is no ataxia, there is no motor weakness. So there is no involvement which can tell that this is a central involvement, only there is vertigo. So in such a presentation, we need to differentiate whether it is a peripheral origin vestibular neuritis or it is a cerebellar stroke which is presented to us in an early stage where the patient is still in the golden period, and our management will be utmost for preventing the stroke to progress. So here we look for a nystagmus, and yes, in this patient nystagmus is present. How do we see whether it is a peripheral or a central nystagmus? Yes, a peripheral nystagmus, we know the direction is always fixed. A peripheral nystagmus, which is because of destruction of the labyrinth of one side, we have already seen, I've explained it to you in great detail, that it will be a horizontal nystagmus with torsion, and the direction of nystagmus also tells you the site of lesion. So the direction of nystagmus, I've told you, is always towards the active side or towards the more active side. So if the direction in this case is towards the left, it means that the active side is to the left, so the involved side will be the right. So now let us have a look at this patient. So let us see if he has nystagmus or not. Yes, we can see he has a horizontal nystagmus towards the left. Fast component is towards the left. And we are seeing that no matter in whichever direction he is looking, the nystagmus is always towards the left. A horizontal nystagmus towards the fast component towards the left. Now here what we are seeing is that this patient, when she looks towards the right, there is nystagmus towards the right. She had a very similar history as the previous case, as the previous patient. And now when the patient is looking towards the left, just notice the fast component, the direction of the nystagmus is towards the left. So the second was a central involvement, a early cerebellar stroke, whereas the previous was a patient of vestibular neuritis. So you should know how to differentiate these two important conditions. The onus is on you when you are sitting in the OPD to differentiate, and this can be life-saving for the patient. So we just saw how the nystagmus of peripheral and central origin are different. And yes, another very, very important test is a head thrust test. Head thrust test is for peripheral pathology, where what we are doing is we are testing the vestibulo-ocular reflex, whether the vestibulo-ocular reflex is normal or not. And yes, again I repeat, if you have not seen the vestibular physiology part, please see the vestibular physiology and the test of vestibular function. There I have explained it very beautifully, why it is done and what it means. So here what we are doing is that by giving sudden impulses to the head, we are seeing whether the eye is able to maintain the fix the gaze on the object of interest or not. So if it is defective, vestibulo-ocular reflex is defective, it indicates a peripheral pathology. So we do the head thrust test. Head thrust test, if it is defective, in defective what we see is saccades. So what is saccades is, if I am keeping my eyes fixed on you and I suddenly move my head to the right. Now what will happen? If my vestibular system is normal, it will immediately send the impulses to the eye and my eye will remain fixed on you. How? Because it moved immediately in the opposite direction to keep my gaze fixed on you. But if the vestibular system is not functioning properly, what will happen? On sudden movement, my eyes will move along with the head. And now to bring my eyes back on the object of interest, to fix my gaze back, the eye will now move back in the opposite direction, much slower than the head, and come back to the object of interest. It will make fast movements to come back. They are known as saccades. So that is what is a head thrust positive. Head thrust positive means there is a defect of the peripheral pathology, whereas in central, the head thrust will be normal. So let us quickly see how the head thrust test looks like. We are now going to see how we do the head impulse test. Now in this test, what we are testing is the vestibulo-ocular reflex. So we ask the patient to keep the eyes fixed on either the examiner's nose or on the camera while we give impulses to the head quick movement to the head, to the right or to the left. Now, if the vestibular system is normal, it will sense the head movement and it will quickly send the impulses through the vestibulocular pathway to fix the eyes on the object of interest. And we will see that in spite of giving quick head impulses to the right or left, the patient is able to maintain the gaze on the desired object. Now let us quickly see how we do the test and how its response is when it is normal. So we can see here, in spite of giving quick head impulses, the patient is fixing the eyes constantly on the examiner's nose or in the center, that is the camera. We just saw how a normal head impulse test looks like. Now, if there is a vestibular pathology, if the vestibular system is not functioning, as in vestibular neuritis, then this will not be possible. And when we give sudden impulses to the head, the eyes will move along with the head. It will not be able to fix the gaze on the desired object, and then it will try to come back to the desired object by making corrective movements, which we call as saccades. So let us see how an abnormal head impulse test looks like. In this patient of vestibular neuritis, please note that the eyes move along with the head and then they make corrective movements to come back to the object of fixation. And those corrective movements are what are known as saccades. This is abnormal head impulse test, signifying that there is abnormality in the vestibular system. The last part of this test is the test of skew. What is the test of skew? Test of skew is, suppose I am looking at you and I suddenly occlude my one eye. The other eye will continue to look at you. Yes, it will continue to remain fixed. But if there is a central abnormality, then when we occlude one eye, there is a sudden diagonal movement of the eye either in the up direction or in the low direction. Either up or down. So that is what is skew. That is what is known as skew. When we occlude one eye, the other eye which is open, actually both the eyes move, but we are able to see only the one which is open, and that happens when one eye is occluded. So when eye is occluded, we can see the movement of the other eye either in the upward direction or in the lower direction diagonally. That is what is indication of a central pathology. So skew will be present in cerebellar stroke or in a central pathology, whereas in vestibular neuritis it will be absent. And the history and examination is the foremost. That is what you do first. You look for any history of inner ear involvement. You look for any history of the central involvement like dysarthria, dysmetria, ataxia. All this will be absent. Cranial nerve involvement will be absent in vestibular neuritis. They will be present. They can be present in cerebellar stroke. Can be present in cerebellar stroke. So yes, this is not just what you have to learn for your exams. This is something which each one of you should know how to do, because by this you can in the OPD itself diagnose very, very early a cerebellar stroke. You can differentiate it from vestibular neuritis and you can start the treatment of the patient very early before the changes have started appearing in the MRI or the radiological investigations. And yes, the peripheral origin nystagmus also follows Alexander law. Alexander law. What is Alexander law? That the intensity of nystagmus increases when the patient looks in the direction of fast component. In the direction of fast component. So in that video that you saw for the peripheral, the vestibular neuritis, was Alexander's law present there? Yes, no. Let us quickly have a look. Let us see how the Alexander's law looks like. Here we are seeing Alexander's law in a patient of vestibular neuritis. So please note that this patient of vestibular neuritis has a typical peripheral origin type nystagmus, that is a horizontal nystagmus with a component of torsion. In this patient, the nystagmus is towards his left. When I say nystagmus is towards his left, what do I mean? Is it the fast component or the slow component? Yes, it means that the fast component is towards his left. So what is Alexander's law? Is that whenever the patient looks towards the fast component, the intensity of nystagmus will increase. When he looks towards the slow component, the intensity of nystagmus is less. Please note here. So let us quickly see how the Alexander's law looks like. So please note that the patient has a nystagmus horizontal with torsion. Fast component is towards his left. So now when he is looking towards the right, he has very minute, the intensity of the nystagmus is very minute, still it is towards the left. Yes, the direction of nystagmus is fixed in peripheral. Again, when he looks towards the left, the nystagmus increases. When he looks towards the right, the nystagmus is less. Yes, so just note, when he looks towards the left, the nystagmus intensity increases.